Thanks again to the organizers for allowing me to speak. And this is a broad topic. Disclosure, I'm both an adult cardiologist and a pediatric cardiologist, and a fair amount of what we're going to spend our time talking about is simply how do we detect myocardial dysfunction. You've heard a little bit about strain and MR and PET and some other things today. And then also, how do we manage these disease burdens when they're present? And I won't bore you with this except just to remind everyone that, heart muscle disease is a big component of this particular disease and obviously has quite a heterogeneous phenotypic expression. But we know that in the initial reports that heart failure was one of the major concerns as far as death. And we know that there's a significant cardiac component in looking at registry data. Up to 70% of patients in their first year of life may be diagnosed with cardiac involvement. And I would encourage you to think about cardiac involvement as it depends on the tool that you use to actually diagnose myocardial involvement. So meaning if you use standard echocardiography, you may detect some things, but you're not going to detect a lot. Meaning if you rely on a shortening fraction, you're going to miss a whole lot of patients. If you use things like strain or deformational mechanics, use MR and looking for things like myocardial fibrosis as indicated by a surrogate burden of LGE, those things are going to give you a higher likelihood of detecting cardiac involvement earlier and potentially offering therapeutic strategies. So when we talk about LV myopathic changes, specifically we're talking potentially about hypertrophy, dilation of the left ventricle primarily, and this idea of non-compaction, which I'll show you some pictures of, potential for arrhythmia or unhealthy heartbeats, the idea of endocardial fibroelastosis. This isn't a disease we see as much anymore, but it was quite commonplace 20, 30 years ago in pediatric cardiology. The concerns for cerebrovascular events, and oftentimes those may be directly related to the presence of non-compaction, and I'll explain why that would be in just a few minutes. And then the concern of sudden cardiac death. So we know there's some historical data that look at Barth syndrome patients, and you can have a wide range of, as I said, of onset of cardiac disease as well as longevity of disease. And most of these patients underwent a pretty extensive evaluation for the year in 2006, so including echo, signal averaged electrocardiograms, which we use more commonly to diagnose a disease called ARVC, arrhythmogenic right ventricular cardiomyopathy, microvolt T-wave alternans, and various serologic biomarkers. And it was evident by this study, at least 90% of these patients had evidence of cardiomyopathy. And once again, it really depends oftentimes on the tool that you use. And the more magnification that you bring to the field, the likelihood goes up that you're actually going to detect something. So these are the 5 sort of heritable types of cardiomyopathies that I deal with, and the 3 that we're going to spend a little bit of time talking about is DCM, dilated cardiomyopathy, hypertrophic, and the majority of the time on left ventricular non-compaction. So we talk about LV&C. We know this is a primary cardiomyopathy, meaning that there are obvious genetic triggers that can result in the LV&C phenotype that are independent of having Barth syndrome. There are numerous sarcomeric genes and other genes that are implicated in this particular disease. And it's morphologically characterized by a very severely thickened myocardial layer and then oftentimes a relatively thin layer. And it's very obvious. When you see compacted myocardium, it's relatively thin. It's kind of the takeaway. It's relatively smooth on the inside of the surface, kind of like this floor. LV&C really has very pronounced projections or trabeculae that I'll show you some pictures of. They're almost like stalagmites if you were in a cave, so these things that are jutting up out of the floor. And I can tell you, regardless of the etiology, this disease is very heterogeneous. And oftentimes patients may become symptomatic over time, but the majority of patients that we follow actually are asymptomatic. So LV&C has a heterogeneous clinical presentation. The most common presentation of this disease that we see is that the ventricle, the pumping chamber is completely normal in size and in squeeze or systolic function. But sometimes it can become dilated and it may not squeeze very well. It can become hypertrophic or thickened, or you can see a mixture of these different phenotypes. We know ECG abnormalities are quite common, actually, in people who have true LV&C. Probably 80-90% of patients with really documented LV&C have some electrocardiographic abnormality. And I apologize, this may be difficult to appreciate, but this is just a list that's actually not completely exhaustive of known genetic triggers for LV&C. So what we're going to talk a little bit about today is when we talk about isolated LV&C is a patient who would have these finger-like projections in their ventricle, but otherwise everything else looks pretty good. So their heart function looks pretty normal. The size of their ventricles and their atria look pretty normal. And most of the time that would be in the setting of being non-syndromic, meaning there are no other extracardiac developmental disorders that would be related to the disease. And we also know the location of where these finger-like projections actually matters, and I'll show you some pictures in a few minutes, but the left ventricle obviously is a three-dimensional structure, and these different sorts of areas can be implicated. It can be high up closer to the mitral valve or in a basal position, or it can be more apical, so at the tip of the heart, which is the common place that we would see this. And those segments usually don't work very well, so meaning that they don't squeeze normally, and it kind of makes sense because the heart muscle in that region has not developed normally. And so the contractility of those segments is oftentimes impaired. And this is just a still frame, two-dimensional echocardiographic image of someone with LV&C. And as you can appreciate, you have these deep sort of crevices that go down, and this would be the tip of the heart or the apex, and this is the base up close to the mitral valve. You can appreciate these deep sort of almost moth-eaten kind of areas within the myocardium. And this is the same here. It's a little bit easier to see. You have these big crypts, where normally this would be all about this thickness would be the entire LV would be about this thickness. And you can imagine that this area just doesn't squeeze very well. And the other thing we worry about are strokes. And it's a pretty simple reason. Blood is in this chamber, and it's beating all the time. If blood goes down into one of these crevices, and that area by definition doesn't squeeze very well, blood has a tendency to clot when it becomes stagnant. And what happens is blood pools in one of those areas, and then ultimately it may flip off, result in a thromboembolic phenomenon, so meaning it could go to your head, your kidneys, your foot, anything else. And this is how we would typically try and investigate LV&C, is to actually put color Doppler on these little crevices. And that's sort of a surrogate for us to know that blood is actually flowing out into those areas. And this is a picture that we produced when we were in Houston that shows that you see blood flowing out almost to the epicardial surface of the heart, which is absolutely abnormal. Now we've started using MRI more aggressively in patients with all types of heart muscle disease, and there are a couple of reasons. One is that MRI is very reproducible. So you can imagine people as they get older, the ability to use ultrasound-based technology becomes quite limited in how well we can see the heart. And there are certain chambers in the heart which we can't investigate completely, such as the right ventricle using echocardiography, unless we use fancier techniques such as three-dimensional echocardiography. MRI gives us very reproducible pictures that we can rotate and analyze in 3 dimensions, which is pretty neat, especially because it also helps us to adjudicate if patients actually have these trabeculations. And this top chamber is the right ventricle. This would be the left ventricle, and you can appreciate down here all of those dropout regions, which is very evident in someone with LV non-compaction. But the other reason to do MRI is the idea that we can actually characterize the heart muscle itself. So we can say, does someone have normal heart muscle, or is the heart muscle abnormal? And we could give a contrast agent called gadolinium, which will hang around essentially in patients that have scar tissue. It's sort of a surrogate for fibrosis, meaning it's called late gadolinium enhancement. So in normal myocardium, gadolinium is washed out. So in normal heart muscle, it should all be black like this. But in patients that have evidence of scar, you see these residual areas where you'll see some residual evidence of this gadolinium contrast, which is a marker of scar burden. And why do we care? Well, one of the biggest reasons we care is that if you think about it, it's nothing. It's not too hard to understand some cardiology concepts. It's just the terminology we use is a little confusing. If you have your arm, for example, and let's say you cut your arm and you scar that area, there's going to be scar tissue there. By definition, that portion of your skin is not normal anymore. Same kind of a thing with heart muscle. You have heart muscle that should be contractile. Well, if I replace that heart muscle with something that doesn't squeeze, like it's hard, like this wood here, you can imagine that area ultimately, if you get enough of that damage in that heart muscle region, isn't going to squeeze very well. So that's what we're using these scar surrogates for. If we can predict who's going to develop scar and how fast that develops over time, those are the patients that ultimately develop squeeze problems. When you develop squeeze problems is when you develop heart failure. So that's part of what we're going to spend our time talking about today. We talk about LV&C, it can be associated with these different phenotypes like I was telling you about. So these are different four-chamber views of the heart. So this is ultrasound-based technology. And these on the bottom right, these chambers are the left ventricle. So that's the chamber of interest for us. And you can see this is one of those patients where the size of the heart's pretty normal, but we have those deep-like crevices down in the apex of the heart. So this is what we would call benign or isolated LV&C. This is one, though, you can appreciate compared in size is dilated, so the chamber is quite big. And if these images were playing, it would show you that the heart doesn't squeeze very well. So that's LV&C in the setting of dilation, so a dilated form of LV&C. The next form is, it's kind of hard to appreciate on these images, but these walls are thickened. And this is what I was telling you about as far as hypertrophic, where things become, the walls become thicker than normal. And then sometimes will be a combination of those where we have thickened heart walls, but the chamber is also enlarged, and that's sort of what we would call a mixed phenotype. This in the bottom middle is a relatively rare form of non-compaction that we see in association with what's called restrictive cardiomyopathy, so the top chambers become quite enlarged. And then the bottom chambers that you can actually get this disease in both pumping chambers, so both the right chamber and the left chamber. The right chamber is actually normally trabeculated, but in patients that have biventricular non-compaction, it's actually abnormally trabeculated, usually meaning that their trabeculations are evident all the way up to the tricuspid valve. And so we talk about LV&C, what are the clinical manifestations? It would be heart failure, these embolic events for the reason I explained. The arrhythmias, so the concerns of unusual heartbeats, which is a very big deal. And then that's typically what we worry about leading to sudden cardiac death. So just a brief overview of what we think about heart failure in general. This is a systemic disease. It's not just about your heart muscle not squeezing well, but it's a dramatic change in neurohormonal profiles and different sort of proteomic profiles that we won't go into today. But at the end of the day, the heart isn't getting enough blood to the body for whatever reason. It either can't relax very well or it can't squeeze very well. And in kids, it's sometimes difficult to diagnose. In a 70-year-old, I can diagnose heart failure relatively easily. In children, it becomes a little more nuanced because they're not going to be able to tell me that they can't walk up 4 flights of steps or that they sleep on 3 pillows at night. So you have to be a little more thoughtful when you're thinking about, well, how am I diagnosing heart failure in an infant, for example? But these are some of the things that you might see, such as breathlessness, tachypnea or tachycardia, diaphoresis, so sweating, especially with feeds. So a child's taking a bottle and becomes very sweaty in a relatively normal or cold room. That's concerning for us. And then failure to thrive is something we pay attention to. And I don't know if you can see this slide. I hope you can read it, but this is how we assess or classify heart failure across populations currently, and this is based on American College of Cardiology, American Heart Association. But it basically says anyone over here at stage A are patients that would be at risk of heart failure. So if you did a heart squeeze exam, like an echocardiogram, their heart looks okay, but we know over time they're at substantial risk compared to the general population. That would include people, let's say, that have diabetes, for example. But it would also include people that get toxic agents to their heart muscle, such as cancer drugs, but also people that have genetic triggers. So people that have a genetic substrate for developing heart muscle disease already are in this stage A for being at risk for heart failure. And as you move over the line, it goes to where people have evidence of problems with their heart, but they don't have typical symptoms associated. Next stage is when they actually do have symptoms. And this last stage on the far right is the one we want to avoid. Those are people that have refractory symptoms. So meaning we're talking about, should we consider a cardiac transplant? And when I talk about heart failure, it really is a syndrome. So you have some reason to have myocardial injury, and you've heard about some of those things today. That triggers an almost irreversible cascade of events that results in a lot of different things. But at the end of the day, it changes the way the heart muscle works. And it's through complex signaling mechanisms and programmed cell death and other things. But it also leads to symptoms. So part of what happens when you have injury and your heart muscle doesn't work very well is you actually start retaining sodium and water. And those things actually contribute to the symptoms when we talk about people who have heart failure. So if you have anyone in your family who has heart failure, they may be swollen, they may have difficulty breathing, this is part of the pathophysiology of that particular symptomatology. And so when we talk about the therapies, which we're going to spend a little bit of time on, these are the traditional therapies that we would use for people with heart muscle disease. So beta blockers, which I'm sure everyone knows some of you may be on them yourself, such as metoprolol, atenolol. Drugs like ACE inhibitors, which are very common in the United States, such as lisinopril, ramipril. Both of these drugs are antihypertensive, so traditionally used for blood pressure, but also have beneficial effects on the heart. Sometimes, rarely, we use this medicine digoxin, which has been around a long, long time, and this idea of inotropes, so intravenous medicines that can make the heart squeeze a little bit harder. And then for people where all these things don't work, we talk about fancier therapies, and I'm going to give you a little bit of data about this in a few minutes, a thing called cardiac resynchronization therapy, which is also called biventricular pacing. And what we're trying to accomplish is simply this. If you look at heart muscle that looks completely normal, which are these two diagrams, and you become this sort of kind of injury pattern, we have some reason to have damage to the heart muscle, ultimately it starts thinning out and it becomes big and dilated. Same down here, the heart muscle becomes thickened, so this hypertrophic kind of phenotype we were talking about. Ultimately, this can go over to the same sort of looking heart where this heart muscle burns out or becomes scarred down. What we try and do with all of these therapies is we're, first of all, trying to avoid going in this direction. But many patients that come to us are already over here. The medicines are attempting to take us back to here or maybe even back to here. This is virtually impossible because of scar burden and other things, but this middle stage is very much a possibility if we're aggressive with our therapies. And so we usually direct what we do based on what we see on our echocardiograms or our MRIs. And the majority of the therapies that we use are directed towards that dilated phenotype, so the big boggy ventricle that doesn't squeeze very well. Most of the data that we use are in populations without associated kind of comorbidities, like we're not talking about Barth syndrome patients, for example, in this particular grouping when we talk about guideline-based sorts of therapies. So what we really wanted to know is we traditionally use these medications in patients that don't have LV&C, but they have a squeeze problem, so they have just a big boggy ventricle, but they don't have those big trabeculations sticking out of the bottom. But we always use these medicines in people that have the non-compaction, so the finger-like things in the dilated ventricles, but no one's ever bothered to ask if it actually works. And so we just started reviewing our data recently. We have maybe the largest cohort of these non-compaction patients, maybe in the world now. We follow lots and lots of these individuals. And we recently just looked at our data to say, well, do these medicines actually work? Because these are the exact medications that I use in our patients with Barth syndrome. And we actually found some very compelling data that they do work. And so we'll be presenting this at the American Heart Association, I'm hopeful. But basically at the end of the day, we had almost 90% of the patients actually showed an improvement in a thing called LVF, so their left ventricular ejection fraction, so how well they squeeze. But most importantly, we also saw that the heart seems to shrink, so it gets a little bit smaller. And the takeaway when we talk about heart muscle function is a simple one. People that have heart disease that don't squeeze very well, their heart looks almost like a basketball. It becomes globular. What we're trying to do is get their heart more conical, almost like a football shape. In that football shape, it actually squeezes much more efficiently. And that's what's going on. This is a surrogate of that the heart is actually shrinking and getting closer back to a more efficient kind of a phenotype. So there are a few other things about this that make it a little more complicated. We know that some data from when we were in Houston as well, this idea that people with LV&C, and we have seen this in patients, even with Barth syndrome, can actually go back and forth between phenotypes, and this is called what's called an undulating phenotype. And it's easier for me just to show you pictures. So you see here, this is that heart muscle that actually is relatively thick and it has that sort of moth-eaten characteristic. This was the next echocardiogram, which was about 4 months later. The patient had actually dilated out, so you can see the difference in the chamber size here and here, and now it's relatively thin. We come over here where it's still not squeezing very well, and these top chambers have even become potentially a little bit larger. And then subsequently, it went back to looking like this heart muscle disease. So we went from one thickened kind of heart muscle disease to one that was relatively thin, and then went back to thick, which is a little odd. That doesn't usually happen in patients that have muscle disease in general. So there's something there that we don't fully understand. But the important takeaway is that the way I manage this disease is different than the way that I manage this disease. So you have to pay attention if you're going to take care of these patients, simply because your medical therapies are going to be different. Probably the largest experience ever published about this type of disease, and definitely the largest in any pediatric patients, is a publication we had not too long ago of a cohort we had from Baylor. And really we're trying to figure out, why did patients with LV&C, what discriminated between who did well and who did poorly? And so this was a single center experience, but it was a large number of patients, and we were really looking at those things about how the heart squeezes, and then also how big was the heart. And we looked at over 200 patients, noting that about 25% presented with signs or symptoms of heart failure, and about 20% presented with some concern of palpitation or arrhythmias. Ultimately, out of this group, 31 patients died, and about 13 or a little over 5% were transplanted. And what we wanted to know is, well, how could we figure out which patients were going down that path? Who was it that was going to die, and who was it that was going to require transplant? About a third of these patients had arrhythmias, so those unusual heartbeats that we would document on an EKG, for example. And about 17% had ventricular tachycardia. That's important. That's the rhythm when you see people on ER getting shocked. That's what they're getting shocked for, ventricular tachycardia. So we don't want that. And then 5 patients had aborted sudden cardiac death, meaning they had cardiac standstill essentially for whatever reason, whether it was a ventricular arrhythmia or something like that. And ultimately that was aborted, whether they broke spontaneously or if someone actually resuscitated them and got them out of that bad rhythm. And so we figured out that there were about 15 cases of sudden cardiac death ultimately in total. And what we figured out was pretty straightforward. We figured out if your heart doesn't squeeze very well, you're at a higher risk of a bad outcome. So that's why we pay a whole lot of attention to imaging studies. We noticed that, so repolarization is an electrocardiographic parameter that I won't bore you with too much, but simply to say that that actually was increased with mortality. And basically this is how the heart resets itself from an electrical perspective. We used to think this was a completely benign finding, and now we know that it's actually not. And then we knew that people that had unusual heartbeats, the arrhythmias, were at very much substantially increased mortality risk compared to the non-death or non-transplant population. And so what we have to pay attention to is that we really have to direct our management at those patients that want to either have bad squeeze problems, because I told you that that's a predictor of a bad outcome, be very aggressive in using medications to try and help with that. And the second is making sure we pay attention to unusual heartbeats and actually doing something about it. Well, let's say that we noticed unusual heartbeats on someone. What do? Well, the therapy, if we think that that is a potentially life-threatening arrhythmia, is a thing called a defibrillator. ICD stands for implantable cardioverter defibrillator. And those are simply shock boxes that live under the skin that have leads that go down into the heart, detect bad rhythms, and will shock patients out of that. And so in this particular population in LV&C, there has been a report of patients who have ICDs that have non-compaction. And what we care about is, does it actually work? So this is that bad heart rhythm I was telling you about. And if this goes on long enough, this patient will die. So the way to treat this is usually through electrical cardioversion. And that's what these defibrillators do. And that's very helpful for us simply because that is one life-saving therapy that we can offer. All the medications I was telling you about, those don't directly save lives in the setting of a bad heart rhythm, for example. But these devices actually can shock people and bring them back out. And so the question is, how does that translate into the Barth syndrome population? That's the thing that we're actually trying to pay attention to and look at. And we've talked a little bit about how we look for unusual heart rhythms. The way we would usually do that is with a thing called a Holter monitor. So we would have someone wear a thing with some patches on it about the size of an iPod, and for 24 hours it gives us EKG data. So every heartbeat, we see what it looks like, right? The problem is, if I use that as my gold standard to say, well, you're completely fine, you don't have any arrhythmias, well, it only means that I've missed 364 days out of the year. So I got 1 day out of 365. If I were fortunate enough to actually catch the patient's arrhythmia on that day, it gives me a lot of knowledge and insight into what to do. But if I missed it, I really haven't done a very good job. So what I would say is that in traditional cardiology, and this is across the board, the way that we do arrhythmia surveillance is relatively coarse. It's not very good. So people have been thinking about this. Well, what if we could do something a little bit better to actually look at people's heartbeats? And this is something we're doing. We actually have a study through Medtronic, which is a company that makes pacemakers, to use a thing called a link device. So this is a Reveal link device. And what it is, you can see how small this thing is. It's much smaller than a jump drive. For patients that have non-compaction, we actually offer this up, and this lives right under the skin, and you don't have to be put to sleep or anything. It's like a tiny little incision that goes under the skin. No stitches, no Steri-strips, no anything. This thing gives me 3 years of continuous data on those EKGs. So if you think about going back to what I told you, 2 big risk factors for people with non-compaction, how their heart squeezes and what their arrhythmia or unusual heartbeat burden is. This gives me the opportunity to look at 1,000 days, essentially, of electrocardiographic data and say, is someone having a bad rhythm and should we intervene? That's pretty powerful, and this device has only been approved for about a month. So we feel very fortunate to have access to it. And we know by looking at some of these things with the shock therapies, we know that some people get shocked appropriately. Some people don't always get shocked appropriately, but at least in this non-compaction cohort, about half of the patients who had some sort of resuscitated event did receive appropriate shocks. So we think that's important data to take away. The other piece was about, I told you, if medications don't fail, and what I hope you take away from this lecture is that our ability to manage myocardial dysfunction in pediatric patients is being greatly improved. And most of that is because of technologies that we're bringing over from the adult side. The problem is, you can imagine that technologies are built for a 50-year-old aren't always translatable to a patient who's 5. Okay? So that's part of what you have to understand. But the general concepts are going to be the same. And one thing that we do in people that don't have very good heart muscle squeeze is a thing called cardiac resynchronization therapy. And this is nothing more than a fancy pacemaker. So people that have heart muscle that doesn't squeeze very well, it becomes what's called desynchronous. So both sides should squeeze in relative unison because the middle chamber, the septum, actually contributes to the squeeze on both sides of the heart. So if it's not in unison, it doesn't work very well. What we do is a fancy pacemaker to reset that synchrony or that unison, and this is called CRT. And this actually has been studied in patients with non-compaction. And interestingly enough, patients do exceptionally well depending on how many segments of the heart have those little trabeculations that I was showing you about. And if you have more segments involved in the heart muscle, your likelihood of getting better squeeze with a fancier pacemaker actually goes up. So the last couple of minutes, I'll just tell you about what is going on, what we've done at our place. So how we manage people that have heart failure or heart squeeze problems is that we assess them very simply. Are they warm and well perfused, meaning can you go up and touch them and they feel pretty warm, or when you go up and you touch them, are they cold? If they're cold, that's a real problem. In some patients, we can use fancy medicines and whatnot to make things better. But in some patients, we can't. And that requires us thinking about, well, what could we do to rest the heart, essentially, to help it out, with the ultimate goal of potentially transplanting that patient. And this is called a Berlin device, or Berlin X-Core. And this is basically an artificial pump that works for the left side of the heart. So these cannulas, this is a patient that actually has support for the right side and the left side. But these tubes actually connect into the heart and then the major blood vessels in the body. And they take the blood out of the chamber, pump it back into the blood vessel, and essentially means that the heart muscle itself doesn't have to work. And this is kind of the way that some of these fancier new generation pumps work, which is called an axial flow pump. And this is a report that we had on a patient that actually was supported with ventricular assist devices, who actually had them on both sides and ultimately had a cardiac transplant. And so these devices, and this patient was a Barth syndrome patient, these devices traditionally would not have been offered to this particular population, but we've tried to make sure that we offer every potential medical technology we think is appropriate to sort of mitigate the effects of bad heart muscle function. And these are just some pictures of these fancier devices, which could all be considered based on the size and age of the patient. And this last device is a total artificial heart, which could also be used in an appropriate situation. So in summary, we would say patients should be screened and have continued monitoring for all the things that I told you about, and simply because if you catch this, you can actually avoid a bad outcome. No one wants to have a patient or a child or anything else that has that situation has the potential for an avoidable outcome, which is bad. And so that's where we're very aggressive in what we do with our electrocardiographic monitoring, like the devices I was showing you, and the heart squeeze problems and offering therapy. And we do think appropriate medical and device-based therapies should be considered for everyone that has these potential problems. Newer imaging strategies, like I was showing you, actually gives us the ability to diagnose heart disease earlier and earlier and earlier. And there are actually therapies that are being developed that can deal with those earlier and earlier findings. We gauge the way we manage the heart based on what the associated findings are. Is the heart muscle thick? Is the heart muscle thin? We do think that sometimes given an aspirin or even fancier drugs like Coumadin are indicated for those patients that have real concerns of getting blood clots down in those trabeculations, because a stroke can be a devastating consequence of this particular disease. And we also know that heart thickness and function can change over time. We know these advanced therapies like mechanical support and transplant may be necessary and should be considered for patients that have advanced heart failure and heart muscle disease. But each patient must be given an individualized approach, and I can't stress this much, in how we actually assess the patient. What therapies are we going to offer up, considering that everything we do has potential downsides. But we feel very fortunate that we've had the access to the full gamut of what I would consider the cutting edge of technological advances for managing this particular disease, and have had good outcome to this point. So with that, I'll stop, and thank you for your time.
Any questions?
Oh, it should be on.
It's the end of the day. They're ready.
Hi, thank you for that nice talk. There's a paper that my former postdoc is publishing. It's coming out in Science in the next few weeks. And it shows a new relationship of how trabeculation actually, the compaction of trabeculi is integrally related to the formation of the coronary vessels. And so that the inner lining of the heart, the coronary vessels from those are actually derived from the trabecular compaction. And many of the things you mentioned are similar to what people with coronary artery disease get: fibrosis, dilation, dysfunction. I'm wondering in these non-compaction patients if there's any evidence of localized coronary vascular abnormalities.
That's right. That's right. You can hear me now. It's a great question. So coronary disease classically in the adult world is described on an epicardial basis. And so without being too boring, if you look at a heart model, there are big red things that come down. There are three of them. Those are the coronary arteries. Usually when we talk about classic coronary disease in adults, it's when you put an angiogram, so you shoot contrast into those, and you see obstruction or blockages into those. No one has really seen that much, even in older patients of non-compaction, unless they had associated risk factors, so diabetes, hypertension, dyslipidemia. However, patients we have seen that we've done coronary angiography on, and also we've done CT angiography, you can see evidence of microvascular disease. So what we're talking about to make this more understandable is that all the blood vessels get smaller, smaller, smaller from an arterial perspective down to a capillary level, right? And that's where oxygen goes across the walls and into the tissues. So all these big vessels get small, 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 small. And eventually they become very small capillary beds. we have seen evidence of disease, localized disease in those areas. Interestingly enough, though, the majority, we do a lot of MRI, and so a lot of these patients that have LVNC, we look in the apex to see how much scar burden they have, which would be a surrogate of an MI, right? That would be a surrogate of myocardial damage. We don't see a lot of LG burden in those patients. Now, it could be that we haven't followed them long enough, and also recognize that using the gadolinium business is not 100%. So there are a fair number of patients, maybe up to a third, who have diffuse fibrosis on autopsy, looking at their MRIs, had completely normal LGE. But you're absolutely on target. This has been discussed for a long time, and this is part of what we're looking for as far as novel gene discovery is, are there different sorts of mechanisms behind just classic, what we would say are sarcomeric genes that are involved in LVNC, and we're kind of seeing some of the same things, so I'll be excited to see the paper. But it makes a lot of sense that if you're not getting a blood flow to those areas of heart muscle, maybe they won't develop normally. Yes, sir?
When you consider Barth syndrome, you're looking at a patient that might have a cardiomyopathy.
Sure.
If you exercise them, wouldn't you expect to see a greater manifestation of a defect? Sorry, thank
It's a good question.
Yeah.
From an ischemic perspective, potentially, and also from an arrhythmia perspective. So we would put patients that are capable on a treadmill or some sort of stress test equivalent. And we do that for all of our patients with non-compaction because we're trying to look for provocation of arrhythmia. Meaning, right. can I perturb a patient enough where they would have ventricular arrhythmia, in which case I would say they may benefit from a defibrillator.
Okay.
It's absolutely true. The problem with many LVNC patients, and I alluded to this a little bit, their resting EKGs aren't normal. The overwhelming majority are not normal. And so if they have inherent ST changes that make it difficult to interpret a stress test, it complicates things a little bit. So you may want to add on doing a stress test plus imaging. So doing a nuclear scan or a stress echo or something like that, which we can talk more about.
Hi, John. Enjoyed your discussion as well. One of the things we struggle with is the diagnosis of LV non-compaction. And I think, as you know, the European Society of Cardiology has it even designated as an isolated diagnosis.
That's right.
So I'm concerned that when you have so many LVNC subtypes,
Right.
that sometimes you can get get them mixed. And if you have, for instance, a hypertrophic cardiomyopathy you've watched and followed and seen burn out,
Right.
and noticed those trabeculations at the apex, and they're high risk for sudden death, do you include those in your LVNC and skew the data?
Outstanding question. So what we're talking about, not to get too far back into the weeds, but this is a continuum of disease, and it's an absolutely on-target point. There are some patients that we see that only have kind of minor sort of finger-like things, and those people are what we would call hypertrabeculated, okay? But they don't have frank cause or meet sort of defined criteria for LVNC, which I didn't spend much time on today. But there are some ratio techniques that we can use to what we say meet classic definition for LVNC. Some patients don't meet those criteria, but they have these bumps, and you think, well, that just doesn't look right. Those are patients we would call more hypertrabeculation, and they're on a sort of a continuum. Some people are small, and some people have almost half the ventricles taken up with these trabeculations. And so it brings up a really good point, is that sometimes we may overdiagnose, or even in some cases we may underdiagnose, and I think it's absolutely true. In the European cohorts, they're more stringent about how they diagnose LVNC, and they aren't as big of believers in the idea of classifying as a distinctive cardiomyopathy. And I'll tell you why. Because of if you look at our data from the paper I showed you and all the large adult data from the Mayo Clinic, for example, people that have that isolated non-compaction, meaning their heart muscle's okay, they don't have arrhythmias, their heart muscle's not thick, all those patients have a normal longevity. That's what we showed in our circulation paper, and that's what the Mayo Clinic has shown. So some people question, is non-compaction truly a standalone disease-based entity? We argue that it is, because no matter what your heart muscle function looks like or how thick it is, it doesn't account for the arrhythmia burden that we're talking about. And even in patients that have normal squeeze and normal size, those patients still die suddenly. So chances are that's some arrhythmia burden that's mitigated by scar tissue or some other repolarization abnormality that we haven't quite figured out. We have a paper coming out of the PCMR, which is a registry, that what I tried to do was actually show LVNC in association with other phenotypes. So let's say LVNC plus HCM, compare it to traditional HCM. Is the outcome going to be the same? Interestingly, the LVNC HCM patients did worse. And I can't tell you exactly why, it's just an observation. But when you look at LVNC DCM compared to just standalone DCM, those patients do about the same. So there may be something about the hypertrophic mechanism, maybe back to some of the vasculogenesis questions that we were talking about. So it's still a very complicated issue, and as you know, a lot of people know, the genetic etiology behind this disease, I think we have a reasonable understanding in Barth, for example, but for the majority of patients that are non-syndromic that have this disease, we haven't adequately genotyped them yet. The traditional genes that would be involved actually aren't as heavily implicated as like an HCM, for example. Yes, sir.
So that was going to lead into my exact question. In this cohort of patients, have you considered using a whole exome approach to look for reasonable candidate genes rather than relying simply on the phenotype?
We just sequenced 250 patients down at Baylor and actually found about 6 novel candidate genes, which I hope we'll report relatively soon. Interestingly enough, one gene that we found that Zaza knows about, we have found one mitochondrial protein that was implicated, at least in this particular cohort. But some of the other ones we haven't quite figured out, but 2 of them actually are involved in cardiogenesis, which comes back to the idea, is there something about coronary microvasculature and the compaction of the myocardium that could be involved here? But most traditional cardiomyopathies go down this sarcomeric phenotype looking for things like beta-myosin heavy chain, for example. Those aren't as heavily implicated in people with non-compaction. So it could be either we just haven't looked the right place. We are doing the whole exome. We were fortunate to have access to a large group of samples, and we have found some novel candidates. But also recognizing, just as any other type of cardiovascular disease, it could be a multi-gene kind of implication as far as phenotypic evidence of disease. So, and you heard earlier, you're talking about one gene in the milieu of 23,500 genes, right? So how does that gene play into everything? We still haven't quite figured all of that out. And we know this, just as you've heard as Barth in general, you can have such various phenotypic representation of the disease. It's same for LVNC. So we have done the sequencing. Hopefully we'll have that in print relatively soon.
Nice talk. I have a question. It is known if cardiomyopathic patients have abnormal level of 4-hydroxynonenal, that is a product of lipid peroxidation.
Is it known?
I'm asking you.
I'm not aware, no.
No? And maybe also in Barth patients, that might be this metabolite around, because it seems that in some diseases there is a high level of 4-hydroxynonenal. So I was just wondering if anybody has tested this aspect.
It's a good question, though. We could definitely talk more.
Because, lipid peroxidation may produce a small piece,
Absolutely.
9 carbon lipid.
Understood. And understanding more about the long-term effects, it's absolutely true. It's a good point. Absolutely true.